And welcome everybody to this week's Maternity and Midwifery Hour. Now we're session 4 of series 9. I have to keep saying that because it seems amazing that when I started in March 2020 at the beginning of the pandemic, it was just going to be for a little while, and now we're a kind of regular feature, which is fantastic. My name is Sue Macdonald, and I'm the curator for the Maternity and Midwifery Festivals and the Maternity and Midwifery Hour. And it's my pleasure to be here this evening with you. And I've got two lovely guests. I have Lesley Turner and I have Elizabeth Duff. So welcome, Elizabeth and Lesley. And because we always do this with our guests, we always ask them for a moment of the week. So could I perhaps ask Lesley for her moment of the week?
Yeah, thank you, Sue. So after we spoke on Monday and you asked me to do this, I did have some inspiration and a most lovely email from a student, and she had just had her exam results and the board had just set, and she said to us that to thank us for all the help over this unprecedented times, because she trained in COVID. She said how much she'd grown over the last 3 years and she wouldn't be where she was today without us. Oh. And it was just such a lovely email, but she said that she'd continue on her journey to be the best midwife that she could be. And it was really touching. So that is my moment of the week.
Oh, Lesley, I've got a lump in my throat.
So it was lovely, really lovely.
Absolutely. Now, those of you who are students out there, you need to I'm not saying you need to go and compliment your teachers, but you need to remember your midwives as well to give them feedback, hopefully good feedback. But that's a lovely, lovely thing to have said to you, because it means a lot.
Did give permission to share it on here today. So
fabulous.
Yeah.
That's lovely. Thank you very much. How about Elizabeth? How about your moment of the week? I like to put you on the spot.
That was such a great thing for Lesley to talk about. I feel well, you said we could have something that's very simple and domestic. And in fact, just now, recently, a couple of friends of mine have very kindly given me spring bulbs in little pots to have indoors. And I went into our dining room and the hydrangeas have just flowered and they were absolutely filling the room with their fragrance. Some people don't like hydrangeas, but I do. And it really felt like spring flowers, and spring is just around the corner. So it might be a bit corny, but it did cheer me up smelling that and seeing the colour.
I don't think it's corny at all, Elizabeth. I think what's lovely now is the sun's coming out a little bit more and the flowers are coming out in the garden. It does feel as though spring might be coming, and I know that some of the weather people are talking about another cold front, which is a bit sad. I'd like some more of the spring flowers, so thank you. That's lovely. Good start to the evening. We're going to come back to our lovely guests, but I'll just do my usual thing of just reminding people, and actually what I must remember to do is say a big welcome, because we have at least 200 people there. Now, for us here, it's just us in a nice little cozy Zoom room, but it's lovely to think of you all there, all over the world, and we've got people literally from all over the world. So welcome to people from Togo, New Zealand, the Netherlands, Uganda, Trinidad, Nepal, New Zealand, did I say that? Saudi, and I'm looking away at my other screen, so I've got all this on my other screen, Australia and Cyprus. So welcome everybody, and I hope you enjoy this evening. Now, this whole maternity and midwifery hour really came from the pandemic. We started to make sure that midwives and student midwives and people in maternity care could really link up at a time when it was very difficult. We didn't have study days or conferences or festivals, and we needed people to get information, to get continuing professional development so they could get on with their revalidation, but also to have information, especially around COVID. Now, of course, the quality of the information now, we've changed it. So there's more updated information, not so much about COVID, though we do still mention it sometimes because it's still around. But we do have a whole bank of information. So I need to remind people, if you're just watching for the first time today, it's useful to know this. All of our work is recorded. So if you miss anything, or you hear someone talking about something, you think, oh, that sounds good, go to Mapflix. is all free to action. You can get anything you like. There's a massive amount of presentations. I think we're up to about 1,100 on all sorts of topics. You can do a search and find lots of information. If you want to have something more kind of directed, there's a whole lot of box sets which Dr. Jenny Hall curates, and she does beautiful little collections with reflective activities and all sorts of additional information. So that's very good if you're doing a particular project or assignment. Do access that. It's really helpful. Also, we'd love you to share. So if you enjoy tonight, which I know you will, share with your colleagues, get them watching, get them involved as well. It's lovely. And I'm going to say a big thank you to our lovely midwives, our student midwives, maternity care support workers, all of the people who work in maternity services and who are working so hard. And I know it's a difficult time because we're getting over COVID. There's some places are having to get over the flu at the moment. And of course, most places are short of staff. And we're going to be talking a lot about that. That's our topic of the day or the week. But there are people who are having to cover sickness and absence, having to work hard to keep that standard of work. So a big thank you to all of those people all over the NHS. Actually, I'm very proud of our NHS, and I want to say a big thank you to anyone who's working in the NHS actually. And also, I just wanted, again, and I know I say this every week, and you might say, oh, she's on about it again. Please look after yourselves. You need to look after yourselves as you look after others. If you could look after yourself as well as you look after others, you'll be okay. So thank you for that. Now, I've got just a quick news feature. I'm going to remind people there's the Dark Lens Conference coming up, and this is celebrating Black and Brown excellence in the perinatal period. Program looks fantastic, and it's a virtual event on the 3rd and 4th of February. So just Google to find information on that. On that point, most of the information you need is on the resource sheet that is with this live session. So you should be able to get it. Right, today is World Interfaith Harmony Week. Part of it anyway. But there's not very much harmony around, except there's been quite a lot of industrial action. There's been marches in Leeds, in Manchester, in London. This is all in the UK. There's a lot of unhappiness with what's happening at the moment. And I know the teachers and the civil service and university staff and train drivers were taking industrial action today. And we support them in getting some resolution to the difficulties at the moment. It's a difficult time to be in public service, that's for sure. And also, I want to say a thing about, I always have a favorite tweeter. Anyone who knows I love tweeting, and my favorite tweeter this week is Martin Lewis, who's reminding us, and he's the money saving expert, and is reminding us just to make sure you've got your passport up to date. Now, for some of you be thinking, what's she talking, passports, holidays? I haven't got time for a holiday, but you might have, and you need to book something at some point. Anyway, passport prices are going up, so keep an eye on that. The other bit of news is Baroness Julia Cumberledge, who is well known to midwives in the UK as being someone who's been so important in improving care and continuity of care for women and babies in the UK, is actually stepping down from the NHS England Transformation Board. So we salute you, Julia. We're going to miss you in your role, but I know you'll be around doing something with the maternity care because you're just there all the time. Also, Women's Institute, and I think probably Elizabeth is going to maybe refer to the Women's Institute, do a lot of good work. They're flagging up, showing the love, power of green hearts to indicate we need to see action on climate change. So with all that's gone on with COVID, maybe climate change has sort of gone to the back of the queue, but we need to be looking at it. And I think I'm right on target now, because this week we're looking at a postnatal care, with the old Cinderella of the maternity services, and I'll probably have Elizabeth squeaking at me for that, but it's one of the terms that's been used ever since I was a student midwife, which was in the dawn of time, and it's still mentioned now as something we need to address. So this week we're going to be looking at some of the factors that contribute to better outcomes for women and babies and families in their experience of care, especially within inpatient services. And Lesley is going to be sharing findings of her research into the outcomes. And I'm personally very interested. Well, I'm very excited about this because a long time ago, I've read some research on nursing staffing, which clearly said where you've got more qualified staff, the outcomes are better. And I always thought, why aren't we doing this in midwifery? Well, I think you'll find Lesley doing a little something here. So I'm really so delighted to welcome Lesley Turner. She's previously worked as a midwife in local trusts and has close ties to practice. I know her heart's very close to clinical. And her previous roles as clinical educator and practice development midwife enable her to supervise the development of clinical skills for midwifery students. She oversees student supervision and assessment, and she's completed her master's in public health and is dual qualified as both nurse and midwife. And she's also an autism ambassador, keen to promote inclusion and support for students and staff with autism. Really good for you to be here. Thank you so much for being with us, Lesley. The screen is now yours. Welcome.
Thank you. Let me just share my screen. These famous words. And okay, so I'm sure you can see that. So I'm delighted to be here. So thank you for inviting me. And so I'm Lesley Turner. You've introduced me beautifully. Thank you, Sue. I'm a PhD student as well as a lecturer. So I'm in my third year, and I'd love to acknowledge my supervisors. So Professor Peter Griffiths, Professor Jane Ball, and Dr. Ellen Kitson-Reynolds, all here at the University of Southampton. So my topic is on staffing. We do lots of research about staffing here in our unit and also on postnatal care. And you'd be surprised to hear that there is no minimum standard for staffing in hospital wards and particularly on postnatal wards. And I was quite surprised about this because you have minimum levels for creches, for schools, for other public services to say there should be one person responsible for so many people, but not in these wards. So that's quite surprising. We do have the standard of one-to-one care in labour, but that doesn't extend out onto other areas of maternity. So that is a surprise. And with the rising complexity of women, then postnatal care is really important. And we know that they do have lower satisfaction with postnatal care than antenatal or labour care, but nobody really talks about it. So it's an area I was really passionate to look at because it has such a long-term impact on women and families and babies in terms of mental health, breastfeeding, bonding, all of those things if we don't get postnatal care right. And the effect of staff themselves. So we've talked about burnout in the past, but how much workload are staff expected to manage on postnatal wards? And that is really the key that I wanted to look at in terms of trying to influence policy and research and practice. So that's the topic for my PhD, but I'll take you through the steps as to where I've got to so far. So moving on. So in 2020, when the world closed down and went to sleep, we started our literature review. So we did a review to look at how many studies are out there, what do they say, do they agree with each other? And we found very little evidence actually about this. And the question was looking particularly about the quantitative association. So we were looking at the numbers to see, is there an association between staffing levels and skill mix, and then relating that to outcomes for mothers and babies? That was the question. And it hadn't been looked at since 2015. So it was looked at before the NICE guidelines came out. And at that time, there were only 8 studies that they had found. So we found that we had really something to contribute because we'd found 21 studies. And I think a couple more have been published since that time. And it confirmed what we knew really, is that increased staffing levels is associated with increased outcomes. And you can see in the middle of the slide here some of the outcomes that were improved and some of the adverse events that were reduced as a result of having better staffing. And this research came from all over the world, so from 10 countries. And in fact, 9 of the 21 studies came from the UK. Only 3 studies included support workers, but actually there's not as much evidence as I thought. And I've been working with the researchers who were doing a lot of the nursing research, and they've got oodles of studies, and we have just very few in maternity. And I was quite surprised that there wasn't more. But you'll notice that a lot of this is in labour. So in terms of the gaps, you can see I've highlighted postnatal care, but there were other gaps. So there's not much research on antenatal care. There's not much research on support staff, even though we're using more support staff, and they definitely contribute to care of families. And there wasn't much looking at midwives combined with obstetric and paediatric staff. So we couldn't really look at the family as staff and how they work together. And really the outcomes they looked at could be expanded. So in the nursing literature, they have something called nurse sensitive outcomes, which actually, or indicators, which actually are indicators that are known to be sensitive to staffing. Things like falls and things like pressure ulcers are sensitive to staffing in nursing. We don't really have that field well developed in maternity. We do have some red flags that have been developed, but most of those are labour. And I'd like to see some more of those in postnatal care, red flags for low staffing. But anyway, this is the list that I came up with, things that I thought potentially could be sensitive to staffing that need to be studied in the future. And I can't do all of this, but these were the things thinking through what could we possibly study, what outcomes could we look at. So things like wound infections, whether documentation's been done properly, whether the meows scoring's been done efficiently and escalated. Missed care, there's a whole body of literature talking about missed care, so care that has been incomplete or delayed care even. And then some of the outcomes for neonates, so breastfeeding rates, weight loss, jaundice. I could imagine all of these things could be influenced by staffing. And then other things like mandatory training. I'd quite like to put on there supervision of students actually for our student population. And the quality of the studies themselves could be better. So a lot of them that I looked at were cross-sectional, but we could do with more longitudinal studies and possibly more individual patient data studies. So there's a whole more PhDs in here really, but this is what we identified. I still wanted to look at postnatal care though, because that was my passion. But I asked service users and staff which outcomes to look at. So we did a consultation. So in a lot of research studies, it's advisable that you do something called PPI, so patient and public involvement. So this was my PPI part. I did this in April 21, and this went out on social media. And 17 staff members and 28 women and families contacted me to say what they thought was important. The women and families said that they wanted more information in the postnatal period, that they wanted more physical help. So some of them had had interventions and they were struggling to mobilise with pain relief, so they wanted more of that help. They wanted help with feeding. They said they really wanted some help to get to sleep. So these wards are noisy, and that that rang true for me really. They can be really noisy places. The midwives told us that I should look at satisfaction, so patient satisfaction, delays in care, admissions to neonatal unit, and the quality of their interactions with women and families. They thought those could suffer. And now I'm just going to tell you briefly about the 2 studies that we've completed and published. So the first time we looked at experience of care. So we wanted to look at women and families' experience of care. And I was lucky enough to find a data source, which is the maternity survey. And this is done every single year in February. I'm sure some of you will recognise this survey. And the data is publicly available through the UK data service. You have to request it, but you can get hold of this data and you can match it to all sorts of other data sets. So I matched it to the staffing data set, and I firstly looked at the trust levels. So how many midwives do we have in each trust? And this is the analysis I'll show you first. So it was a survey. It went out to all women who gave birth in 2018 in February, and the response rate, I've got it somewhere, 37% response rate, which is not too bad for a survey. And I picked out 4 questions in that survey which related to postnatal care. But if you wanted to do more research, you could look at other questions, because there's loads of information in there. And I would encourage researchers to maybe look at this. But the 4 questions I picked out were to do with delays in discharge, whether they felt staff helped in a reasonable time, were they given information and explanations, and were they treated with kindness and compassion. And for 3 out of 4 of those outcomes, trusts with a higher number of midwives in the organisation scored much better. And you can see some of the statistics here is that they scored much better in 3 out of 4. And the 4th one, with kindness and understanding, there was no difference. But this gives us some evidence that staffing improves the patient experience, which is what we haven't really got already. So that's new. And in terms of the size of the difference, we estimated that about 6% fewer women would have a delay in discharge. So it doesn't sound like a lot, but when you multiply that up through the whole country, that's actually quite a lot of women potentially benefiting. The next part of the research, so this is a second analysis. This was also done on the same maternity survey, but it was done the year later in 2019. And I chose the year later is that there was a new data set on the block called Care Hours Per Patient Day. And this data set adds up all the staffing hours in that period. And it also adds up how many women were on the ward at midnight. So you get some idea of workload. And it's also at a ward level. So I can drill down to see what's going on the ward rather than just what's happening in the organisation. And so there were real benefits to using this data set. And also it told me about support worker staff for the first time. So that was really good. And what we found in the top box, you can see that the findings were very similar to the other analysis. So at trust level, the number of midwives in the whole trust did seem to influence the quality of postnatal care. The middle box was a bit surprising because when we looked at the midwives on the ward, at the ward level, postnatal wards, we found that the relationship that we thought would be there, it wasn't there. And one of our explanations, it might be that the midwives might be there on paper, on the rosters, but are they really there all the time? And I've seen in the literature and I've seen written down that during a shift, sometimes midwives from the postnatal care wards are often moved to support labour care. And it could be that they're on paper, but they're not always there. And I'm told that anecdotally that happens in practice. And in the bottom box, we did find a positive relationship between support workers and women saying that they had help when they needed it and they were treated with kindness and understanding, which shows some support for their role in that area. But this analysis is not all. So I've gone on to look at safety and outcomes. So this is just patient experience. And this is what I'm working on at the moment. So I've got a new data set. I love data. A new data set from the Workforce Health Outcome Study, which is a huge study. It's individual patient data and it covers 4 trusts over 5 years. And I'm able to look at the outcomes in blue. So readmission rates, transfers to neonatal unit or back to labour ward, some adverse events and mortality. And I'm hoping, this is quite a strong design, having a longitudinal design. We're linking directly, we know what exposure of staff that women have had, and we can link that to their outcomes. I don't have any results to share with you just yet, so that's just coming. And then finally, what does this contribute? So why does this matter? Is that we've been able to use quantitative methods, which is just one type of research, but we've been able to link patient experience and hopefully outcomes, but we're working on that, to staffing and skill mix. And it just gives us more information about staffing and it gives us that evidence we really need. So this is the additional studies that we'll hopefully publish, and it supports midwifery and support worker staffing. We have used a rigorous approach and we've published in peer-reviewed journals, so we have had the work scrutinised, but it really spotlights postnatal care and why staffing matters and which outcomes could potentially be affected. And I think that's really important. We haven't been able to do everything, so we haven't been able to account for things like staff training, whether they're following best practice and culture, and things like continuity models. So we haven't been able to do everything, but we have been able to demonstrate a link between staffing and outcomes and experience. And we are delighted that our work was noticed. So on Twitter, Professor Jane Sandel retweeted one of my papers, and Elizabeth Duff retweeted it again, and she said that this evidence underlines the urgent need for better care on postnatal wards, and she's going to come and talk to us about that. But, thank you very much for listening, and these are just my acknowledgements at the end. So thank you, and any questions later, I'm very happy to talk about it.
Okay, well, thank you for the reminder, Lesley, to the audience to, if you've got questions, start putting them in the chat box, because then they'll come through to me, and then we can discuss those after Elizabeth's session. I'm very interested in these paper midwives. I think I've got this picture of paper midwives, and we know it happens, but it's good to have it kind of recorded in that way, because that's actually having an effect, isn't it? Because you're not able to get the evidence you were looking for. And I love the family of staff, that other term that you use. So I'm going to look forward to the questions coming through. So we've got our second speaker, the lovely Elizabeth Duff, who we've had before. So people will know Elizabeth very well as the Senior Policy Advisor for the NCT since 2009. And she's got a wide portfolio covering affecting patients during the first 1,000 days, childcare provisions, and to maternity pay also. She's a very experienced speaker, and she very much champions the needs of parents at a national and international level. She's been in journalism and communications. She's chaired the Camden Community Health Council and been the vice chair of Camden and Islington Maternity Services Liaison Committee. She also writes very much, as well as tweeting for Midders and the Midders Digest. So welcome, Elizabeth. The screen is now yours. And it's great to see you.
Thank you very much indeed for that lovely introduction. I'm always worried when people describe me as an experienced speaker. I mean, for a start, it sounds like I've got a lot of grey hairs, which is true, but also it looks as though I should be able to find my shared screen.
This is always the joy of IT for those of you watching.
It says I'm screen sharing, and I hope it's loading up now. Just to say, while this is happening, and I hope it is happening, how wonderful actually to follow Lesley, who has presented, as she rightly said, research with a rigorous approach and properly peer reviewed. I'm not going to talk about research like that. I'm still worried about my slides because they don't seem to be.
Yes.
My left arrow on the keyboard is not happening.
Maybe just be patient. We have all these little IT.
Apologise. This should be
no worries.
happening.
No.
Okay. 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 That is obviously my last. So perhaps I just need to go all the way through. Right. Not too many slides, fortunately. So we now are at the beginning. Apologies for that. And I will try and make sense now. So here we are. The NCT responded to a call last year from two all-party parliamentary groups, the one on maternity and the one on baby loss, Both of those groups, obviously made up of MPs and supported by maternity organisations, were desperately worried about the issue that we all know about, lack of staffing in maternity care. They were called out to all sorts of organisations, including ourselves, for evidence to show how this was impacting women. So the NCT, where I work, was able to carry out a pretty quick survey. Again, my colleague Jennifer Holly, who actually carried it out, was keen to say this is not a rigorous approach. It was carried out via social media, and we knew that that wouldn't be demographically representative. But the sort of responses that we got were matched up so much with what we were hearing elsewhere. We're not so worried in this case about full representation, because I don't think many people would argue with the sort of comments and numbers that came back. So it was called, it is about women's experiences of maternity care. It was women who gave birth within 12 months before July last year. So it's 2021 to 2022. And the actual title is a quote from what one of the women very tellingly said: "Too few midwives are carrying too heavy a load." And I imagine that will resonate with a lot of people who are actually in the service and those outside it, but knowing what's going on. We asked questions of women which were partly based on some of the questions that appear in the Care Quality Commission maternity survey, which Lesley talked about just now. They were also designed to identify the red flag events, which are criteria defined by NICE, the National Institute for Health and Care Excellence. And red flag events show where delays or inadequate care happens because the staffing is not up to the level it should be. Now, my first few slides are referring to the maternity journey of women overall, and then we'll move on to postnatal. But these do show that there were a lot of red flag events, far too many than should be happening. They're not necessarily dangerous. It may be a delay that actually doesn't have an impact on the outcome, but some of them certainly will. I wanted to put this in. This is an absolute, obviously, the words from one of the women who responded. And it is a very nice thing to read because in spite now, I beg your pardon, these slides are moving themselves, but to give you a chance to read this, this is a woman who had some troubles in what was happening during her birth, but she absolutely appreciated the way that the midwives were cheerful and caring and kind, and I love it, upbeat and perky. I know a lot of midwives can't say they feel that, but obviously for this lady, fantastic. She got that impression. But she knew they had a lot to do. They were on the clock. They were experiencing long and unsociable hours of work. And that obviously came over in spite of the fact that she describes her care as amazing. And we did hear this sort of comment quite often. So we asked about personalised care. And around 65, just over 65% of women did feel listened to nearly all the time. So around 2/3, that's good. But unfortunately, that's a third or more than a third who did not feel listened to. And that is something we don't want to see. We go on to ask about women having the right amount of time and information and support to make a decision. Decision making is very important. Perhaps it might be said more important in intrapartum care or late pregnancy, but apologise for this moving back and forth. I think the slides are moving before I'm clicking, but let's try and keep to it. So around half women did not have all the time and support they needed for decision making, quite worrying. Now, delays in care, unfortunately, this is even worse. Only 44% of women said they were always able to have the care they needed in a timely fashion, and the delays were most common after giving birth. No great surprise because of all the things we've heard. Now we move on to the more detailed description of postnatal care, and unfortunately, these are the words that were used quite, unsolicited by women: carnage and hell and total chaos. That was how women felt when they were in the postnatal ward, and described their own feelings as unsupported, abandoned and unsafe, which is a desperately worrying thing. We know that women are very vulnerable at that time. Their babies are vulnerable. They worry about the babies, and some of them are, it is the beginning of really poor mental health, because the anxiety is so damaging shortly after, often quite a worrying birth. And this is clearly something that needs to be addressed. This is again a long description. A woman who described being very aware of the lack of midwifery resource. Again, these things are clicking on without my doing so. I do apologise, and I hope that's not spoiling the way you're absorbing what I'm saying. It's very sad here that she described staff in tears due to the pressure they were working under. Again, she's expressing her own sympathy. She knows that's not the fault of any individual member of staff. But the result is, as in her last few words, I didn't feel my baby and I were safe. And again, this is, as you'll all feel, I think, very heartbreaking to read. It's an awful environment for the midwives and the support workers, and it's an awful environment for the mothers and their babies. And many of them said they just wanted to get out. But of course, discharge was quite often delayed as well. At the end of the report, which has been written up around this survey that we did, and I'm sorry to say there have been delays in actually publishing this, and of course it is, it would be that it's actually going to come out next week, and I'm hoping we may be able to add the reference to the list of references that Sue will be putting together by the end of the week. But in any case, it will be out there. So we had 8 recommendations at the end of our report altogether. Some of them are what you might say is the very obvious ones, but you can't leave them out. They resonate with a lot of recent reports, such as the Ockenden report on Shrewsbury and Telford, the Kirkup report on East Kent, and so on. Investing in the workforce, listening to women, promoting relationship-based care, better multidisciplinary teamwork. Number 7, we have put in enabling partners' presence at in-hospital postnatal care. I know that this is improving as time goes on, but certainly last summer and the months before that, women were still having that damaging impact from the lockdown era restrictions, where they found their partner was only able to come in some cases for an hour a day. I think one woman found she wasn't able for him to come in at all in the postnatal ward. And that was absolutely impacting, because this particular individual woman, the effect of her epidural lasted quite a long time, so she couldn't walk at all. She was not able to get help to get to the bathroom. She couldn't reach any food and water, and she couldn't reach her baby. And nobody came when she asked for help. And that, again, was an absolutely catastrophic experience for her. What I want to go and talk about, and is a little bit more positive, I hope, we put in as our last recommendation on postnatal care, we want to bring together a coalition of policymakers, service users and professionals on postnatal care. And we want to call for a complete end-to-end review of this period of care. ideally from birth to more than 6 weeks, because I think many women need more care. And we know, looking at the results, for example, from the Embrace report, which looks at the very tragic deaths that happen up to a year after birth, and some of those are pretty much relatable back to what happened at birth or in the early weeks. So we think probably should be longer. But we would like to see a national level review, which could look at the whole area. Often, and here I've put the problems, particularly postnatal mortality, are due to mothers falling through the gaps between those threadbare services. And you will know them. It moves with the woman from the acute care area in a hospital to community midwifery, sometimes from a different trust if the woman has given birth out of her immediate area. The midwives visit as much as they can, but sometimes only one home visit in the first few days, and the care swiftly passes on to health visitors who are employed and commissioned by local authorities. And in many cases, we've heard of health visitors having a caseload of over 700 families, and that pretty clearly means for the next few weeks many women and their babies are not receiving a visit at all. They may be told to go to a surgery or a hub or a clinic somewhere, but especially if they've had a difficult birth, a caesarean birth, where they're told not to drive, etc., they won't be able to get there, and they're getting pretty much nothing. We know that most women now are getting a check from their GP, but it isn't always what they expect. Some GPs have not been trained and refreshed in this area, so they're not absolutely up to date. We know that's not anyone's fault. GPs have had a extremely pressured time over the last few years, and it's not possible for all of them to have carried out the right training. But it does show that postnatal care at the moment is sometimes provided by 4 different institutions. Information doesn't always pass from one to the other. All those professions are overstretched and understaffed, and it means that women are falling through the gaps between them. So one thing we are going to do is respond to the Health and Social Care Committee in Parliament is launching an inquiry into prevention in health and social care. Now, to my mind, and I hope that is in agreement with the MPs on this committee, getting postnatal care improved would be an immense step forward in preventative health care. The number of things that can happen to the physical and mental well-being of both the mother and the baby that result from poor care in the postnatal period is enormous. It may be simply the information that they need in terms of follow-up from some complication of pregnancy or birth, women who suffered from hypertension, from gestational diabetes, from cardiac problems. They need support, they need follow-up, and they need information for their lifestyle advice, to know whether they need to take certain actions, whether they need to be taking medication, and so on. Lots of things in that area. We know that women suffer pelvic health problems after a birth. There is more help in the NHS for this, but again, it's not very well coordinated, and some women miss out on that and have really distressing problems of incontinence that go right on through the rest of their lives. Babies suffer from things that are not picked up when the health visitors are not there to spot their physical and emotional and mental development, things that should be picked up straight away in that postnatal period and onwards from there. You can see from this slide, I've got a week to do this, and I'm trying to pull together some support and ideas from other organisations and other individuals to try and get this over. Of course, there'll be many other people trying to get their views into this major inquiry. If we have anything to do with it, we will make sure that we're on that short list at least. but I hope it will at least make people think postnatal care is not just about midwives, it's not just about hospitals. There's a huge amount that needs doing across all those areas of healthcare, and this could be one way to get the powers that be to think about it. So I'm going to stop now. Thank you very much for listening to me. That's where you can find me if you want to read my tweets about postnatal care and many other things. And thank you very much for asking me.
But of course, also, Elizabeth, you've left your email there. I presume that you want lots of people to contact you with just ideas, maybe, or comments that can be put in.
Anyone who has an idea to put in about this particular proposal for the inquiry, it's got to be very quick and it's got to be very short, because we have the whole proposal has got to be within about 700 words, and that's not very much.
Gosh, no, it isn't.
Yeah, it's got to be very concise, and I'm finding that extremely difficult because, as you know, Sue, I can go on forever, just turn the tap on and I'll go on talking about postnatal care. So I will absolutely have to be shut up about this, but it's a very good discipline to try and get it short.
But it's a great opportunity. I mean, thank you for sharing that, because now we've got some of the work that's been done and some of the work in progress. And I think that's useful for midwives to know that it's not just sitting there on a cupboard like my books. It's actually, people are actually trying to push things forward and influence policy. I mean, I love the idea of the National Coalition. I mean, that would really put impact and importance on postnatal care, and it might not be lost along the way. Now we've got some questions coming through. Now, forgive me if I look away every now and then. I have two screens and the questions come on my other screen. So I'm going to first of all start with some questions for Lesley, and I've got Kim Watts. Hi, Kim, who is saying, in several hospitals, the answer to low staffing levels is to use registered nurses to help staffing on maternity units rather than midwives. Did you find any evidence to support this move and its impact on outcomes? Good question, Kim.
Thank you, Kim. Yes, I was aware that this was happening too. So in the studies that I was able to look at, then I wasn't able to capture registered nurses. But in the study that I've got in progress at the moment, then I can look not just by having registered staff, but I can look at, are they nurses, are they midwives? And in fact, there are very few nurses in the data set that I'm looking at. So I've done the descriptive statistics to look at what I've got, but actually there are very few registered nurses in those 4 trusts that we're looking at. So, and I can also look at nursery nurses and support workers, but I think it might be too soon to look at that data. And it might be in a few years' time, you might see more nurses in the workplace, possibly, and then we'd be able to tell what effect that might be having. So, yeah, I know the Royal College of Nursing put out a document about nurses in maternity, which is quite an interesting read, and it talked about them not being very well prepared for the role. And in my library of references, that's something that came up, is if they are being used, actually, are they well prepared to take on some of those roles? Because midwifery is different to nursing, but there are some overlap. But it's a really good question, Kim. Thank you.
Yeah, so it's a tricky one, actually, and it's sort of the question and the answer illustrate how different units operate, and how, I mean, I instantly think, gosh, nurses, well, they're as precious as midwives, and but your point about being prepared, you can imagine it, when any of you who are nurses and have now come into midwifery will remember how scary it felt and how different, it's like a different language, a whole different set of stuff that you do. And you don't forget that in a hurry. Anyway, I'm going to get on to the next question, which is from Sarah. And Sarah hi Sarah, says, did you identify any particular ideal staffing? I assume that's staffing numbers or ratio.
I would love to be able to do that, but actually that's really difficult. And a lot of the research, even in nursing, where they've done a lot of research, it is more difficult to pinpoint what the staffing levels and ratios should be. So at the moment, we're just looking to see, is there a relationship and how strong is that relationship? And actually going on to predict what is the optimal relationship would involve fairly complex modelling, looking at the women themselves and families. So in terms of, what care, what complexity they have, what dependency level, maybe gestation of the baby, it would involve quite complex modelling. I'm not saying it's not possible, but at the moment, we're just trying to establish the relationships to see how important is staffing among the other variables, because actually, when you look at all the other variables all lined up in modelling, you can see that some of them are actually much more predictive than staffing. So a woman's type of birth, her age, the gestation, so all of these individual risk factors tend to outshadow staffing. And in fact, it is an effect, but it's much smaller. And it's quite difficult then to go on and predict to say, if you did this many staffing, then this would be your outcome. We're just at the beginning of our exploration, really.
And I was thinking, as you were presenting with that big list of areas, I thought, this is, any of you out there who are interested in postnatal research, there's huge work and questions to be done. But I was wondering if there's also the model of care, of course, because you can talk about relational care and continuity of care. And did you have different units who had different models of care that you could kind of compare quite well?
In the scoping review, some of them did have different models of care, and they've looked at the staffing compared to their model. But in the review that we looked at, it was just the numbers of whole-time equivalents we looked at. We weren't able to get to that data on models of care. But yeah, there is a lot more research that's needed in staffing, and the way you configure your staffing, not just the numbers, so how they're arranged and how they work together. And there's more staffing now in certainly nursing, looking at nurses plus other people, because we know that they are, as I said, a family, and and they work together. So it's about how the team works together as well. In nursing, there is some research which does give an idea of safe levels, and this has been mandated by NICE, and they recognised some of the research which was done by Professor Griffiths, who I'm being supervised for, and they found that if you have more than 8 patients to one nurse, then they're much more at risk of harm. So, and that's not saying that 8 should be the number, but actually after 8 patients per nurse, there's much more risk of harm. And we know that on the postnatal wards, how many do midwives look after if you include the babies?
A lot more.
Interesting,
more.
isn't it?
Is magic. Yes, absolutely. Absolutely. I have the number 8 in my brain, so I think that's been tweeted and discussed. So thank you. That's great. Okay, and Maxine Anna, Maxine, I hope I pronounced that correctly, says the use of MSWs will have a great impact on ward. Do other hospitals do this? I think you talked a bit about healthcare support workers and maternity support workers.
I think in the new data that I've got, all the trusts that I'm looking at are using maternity support workers. So, but there is no recommendation as to what the ratio should be. And it was anywhere between, registered midwives were about 65% to about 75% of the postnatal ward staff. So it is quite variable, and different trusts do different things, but they might be caring for different types of women, or they might have transitional care attached to them, so we might see more nurses there. So it is fairly complicated, but it is a new area to research, and it's really interesting. I do get a bit lost in the data and sometimes a bit sidetracked, so I have to keep bringing myself back to the question, because you can look at all sorts of things. So
I know. Well, you're making data sound very exciting, Lesley. So those of you out there, just remember. Okay, so I've now got some questions for Elizabeth, because she's having a quiet time now. And this is Amber. Hi, Amber. Says, do any trusts allow partners to stay the night on postnatal wards? Well, that could be either Lesley or Elizabeth, but I'll ask Elizabeth anyway.
I don't have figures, and I do try and listen and see what is happening when people report on that, but I haven't got national data. I do know one or two that do in London. It obviously, during the lockdown time, that would have disappeared completely. But certainly one of the North London trusts that quite close to me had that in place before, and I believe they have restored that. Appreciate there's sometimes been problems and some partners haven't behaved in the most considerate way and have gone and used the shower for about 20 minutes when women are waiting, which I think there really are ways that if a partner is going to stay overnight or at any time when it might disrupt or upset other women, they've got to be under agreement to be extremely considerate, extremely discreet, and simply stay with their partner and baby. I do understand the difficulties there. So I don't have that data, but I do hope that that is being made available, especially if a woman has difficulties in mobility and really needs to be helped. And we just know there aren't enough staff to do that. So if partners can stay at least perhaps the first night and make sure that the mum is at least up and about and able to do the basics for herself and her baby. It's so distressing to read of women who can't actually reach the water that's been put on the other side of the bed or a metre away or something. And goodness me, when you've been through a birth, whichever sort of birth it is, you need to be rehydrated. You're trying to initiate breastfeeding, 85% of women do. That's another thing. Clearly, you need to be.
I think it sometimes
supported
helps.
And be able to be. We would like every trust to consider that and maximise the amount that they can reasonably enable partners to be there. It just makes sense.
I guess it comes down as well to facilities and if you've got enough privacy for different groups of women and cultures and that sort of thing, and also having your own washing facilities, for example. I love that. I've got this picture now of this man, or it could be a woman partner in the shower for 20 minutes. So that could be very upsetting for women. They're desperate to get in the shower themselves. Okay, I'm moving us on. I'm moving us on now. Nicola Clark says, hi Nicola, says, can I ask, are NCT breastfeeding counsellors or postnatal supporters encouraged to assist in local hospitals and centres anywhere in the UK or Northern Ireland?
Well, once again, a very good question to which I cannot give precise answers of where they are and where they aren't. In most places, we do have breastfeeding counsellors and also breastfeeding peer supporters who are trained to a different level, but can certainly help women to a certain extent and identify problems and refer to a breastfeeding counsellor. So we always offer those two levels of help. And of course, we have a support phone line, which is very responsive, and breastfeeding counsellors are paid by us to staff it and will call women back. And we have an enormous amount of women just expressing so much appreciation about the phone line help they've received. Again, of course, at the time when this our survey was held, it was moving.
Oh, I think we've got a connection issue with Elizabeth. So I'm going to sort of move on a little bit while Elizabeth's line might get better. Juliet Samuel, hi Juliet, in Essex, says, hi all, Lesley's research has the potential of highlighting
infection risk.
Okay, your connection's not very good, Elizabeth, so I'm moving on to a question from Juliet Samuel, who says, Lesley's research has the potential of highlighting the impact of postnatal care due to poor staffing levels. How is this envisaged to impact senior management in care planning in light of current reduced midwife shortage? Great question, Juliet.
So impact is something that we do get measured on in universities. So they when we are funded to do research, or we do research, actually, it's really important that we consider the impact and how the work is disseminated. So I'm doing my PhD by publication, which means that I'm publishing as I go along so that the messages aren't lost and they're not old. And in terms of impact, even by coming along today, then that's some evidence of impact, and for all you to think about the impact that you're having, and when you're short of staff, what are the consequences. But in terms of policy, I did contribute to that consultation that Elizabeth talked about. So it was an all-party parliamentary group, and it went to the House of Commons, and the evidence from my report actually did go into that report, which is publicly available, and I think it might be on the reading list that Sue will disseminate. So in terms of impact and getting the message known, is that we do want to highlight the results of our research. And one of the reasons that NICE didn't make a recommendation in 2015 about staffing is they said that there was a lack of evidence. So my thinking is that we get the evidence, and we can evidence that. And that was one of my reasons to think, well, actually, there is evidence, and we've got it together in the scoping review. We're producing more evidence. It's a shame that we need it in that way, but actually it will be helpful. And I do plan to plough it back as much as possible.
I think that's the benefit of this sort of research and being able to publish as you go, because I know some research has to almost stay a secret until it's published, and so this is really sort of like live research, is fantastic. Now I'm going to move. We've just got a few comments, because this hour, as I always say to people, this hour goes so quickly. So I'm going to say Amber, hi Amber, says a lot of more postnatal information could be shared in the antenatal period to avoid overwhelming volumes after baby arrives. I guess there are staffing issues, time restraints in antenatal care too. I think it's all I think one of the things that any of us would say is there's a lot of information going to women, but it has to be relevant. It has to be time managed a bit, doesn't it? So that was that. And then
I think there's also, sorry, I was just going to say, I think there's some evidence that women are almost reluctant to learn things about what happens after the birth, that some women are very anxious about what happens with the birth. It kind of ends for them when they've got a baby in their arms, and we trust and hope that will be the case for all of them. But sort of learning about what happens after that is almost a kind of jinx for them, so they shut it out. That won't be for everyone. I know a lot of people would like to hear more about what happens afterwards and get that information, and I think it's always worth trying, because it probably needs repeating at every stage, because women have so much to take in. They have so many decisions imposed on them, as we saw, without necessarily the right support, and just being able to prepare is really helpful.
And I think it's like what you were saying about women who can't get to the water. I think sometimes practitioners need to remember what it feels like to be a patient or a client, and how alien that can feel, and how sometimes what we take as normal information that's quite manageable becomes massive for women and their families. I think that's a good point, Elizabeth. So we've got lots of questions about the NCT. Now, I'm not going to answer them all now, and nor is Elizabeth, but I'm going to say go and have a look at the NCT website, which is fantastic. Loads of information there, all about NCT classes and the breastfeeding counsellors. And I'm going to say, I've got one comment from Kim Watts, who says, the issue of no stated staffing levels for the wards is a real issue for management and service leaders in developing business plans for increasing staffing levels. And I think that's a good point, which I think Lesley highlighted. We need that evidence, to inform. And Charlotte is asking, do you think by offering more infant feeding support on postnatal ward, this would improve the care? I might throw that at Elizabeth as a final question. Or is it a comment? I'm not sure.
It's one of the things I would say very broadly, there's 3 themes that come up in all the responses we've had. Lack of support for feeding, and it isn't just breastfeeding, even women who've decided to use formula, but they're not sure how to do it, or the baby doesn't take it well, and so on, and they get anxious. And there's their own mental well-being is another theme, and of course damage to the perineum resulting in poor pelvic health. But it isn't just those. I know all of those have been addressed to a certain extent in the NHS, and I'm glad that they have. But it needs, a lot of women have comorbidities. They may be worried or suffering from one of those things, but also worried because they had gestational diabetes, they had hypertension or something. It shouldn't be different places that they have to go to get this care. It's very tough navigating that labyrinth of things that are on offer, or realizing when it's not on offer. It's really difficult, and these are women who are struggling, caring for a newborn, sleep deprived, sometimes very sore or suffering from infections or something themselves. We have increased number of readmissions to hospital, which is horrible for the mother, horrible for the baby and the family, and pretty horrible for the hospital. And it is just when the care can improve, so much is going to be prevented that is disruptive to that, what should be life of a new family.
Wonderful. I don't know if Lesley wants to say 1 or 2 words as we're coming to the end.
Yeah, just really to say that I think the staffing impetus just shouldn't just be on labour care, and I know that's where some of the terrible outcomes can happen, but terrible outcomes can happen in postnatal care, and it can be sometime later. So it might be psychological health, mental health, it could be other things like infections. It does happen, and a lot of morbidity happens in the postnatal period. So I think when we look at red flags, when we look at staffing, don't move midwives from the postnatal ward to cover areas if you can help it, because they're there for a reason. And although I can't prove that's what happened in the staffing, then that's what people tell me, that actually you might place midwives there to start with, but they are moved around and it's not been given the priority area that it deserves, and those women do deserve better. And I'm happy to be contributing in whatever way I can.
Fabulous. And we're back to the paper midwives. We don't want paper midwives. We want midwives where they need to be. Well, thank you. A huge thank you to Lesley and Elizabeth for joining us this evening. It's been fantastic. And I think this debate's going to go on. And I know because Lesley's publishing more day by day. So I foresee that both of them are coming back for a return visit. And I can see by the discussion that's gone on, you'd like them to do so. So that's fantastic. Thank you so much. Now I'm going to just remind people that the resources are available on the website and on Facebook on Friday. And of course, for those of you who like a 6 o'clock in the morning podcast, this will also be available on Friday morning. Next week, we've got Trixie Macquarie talking a bit of continuity of care, which kind of links in quite nicely. Don't forget to book in for the Safer Beginnings Conference for Healthcare Professionals and Educators in Maternity. That's the 3rd of March in London, 10th of March in Manchester. Next Tuesday, if you haven't booked, is the London Festival. Maternity and Midwifery Festival on the 7th, on the Tuesday. So I'm sure I'll see some of you there, not everybody from all over the world, but thank you so much for joining us all over the world. In the meantime, before we see you next week, stay safe, stay well, and look after yourselves, and we'll see you then. Take care. Bye.